Good afternoon to everybody. My name is Miguel. I'm a consultant endocrinologist here in Coimbra, so welcome to Coimbra. And for those who don't know, Coimbra is one of the oldest universities in Europe. According to our local history authorities, it's the second oldest in Europe. I don't have level A evidence for that, but anyway, I pretty sure believe that it deserves a visit for our invited guests. So, for me it is a great honor to introduce Professor Neil Gittos. Professor Neil is a consultant endocrinologist and honorary professor at University of Birmingham. He is what I would call a super specialist in this field. Just a brief note to say that he leads the Metabolic Bone Disease Unit in Birmingham, several scientific work streams through the Royal Osteoporosis Society, and I have to look because I may miss some of the precise names. He's a member of several guidelines and consensus groups, like the National Osteoporosis Guideline Group. He is directly involved in the International Task Force and the European PARAT program, and of course he is a co-author of the recent guidelines of the European Society of Endocrinology. With all this scientific background, with all his expertise, and with all his communication skills, I'm pretty sure you are going to have a very, very good and interesting presentation, and we are looking forward to having it. Professor Neil, please go ahead.
Thank you, Miguel, and good afternoon, everybody. Thank you for having me amongst you today. I was hoping for some sunshine coming from the UK in January to Portugal, but I've been let down. But it's great to be here and in these surroundings as well. So my task is to talk about conventional therapy for hypoparathyroidism. And of course, that's what we have in most countries at the moment, is the very basic approach to managing hypoparathyroidism. And Stefan has very nicely set the scene as to what's going on, what's missing, what we've been doing, and perhaps what we should be doing. And I think this session should be commended for its emphasis on practical management. I think very rarely do you go to medical scientific meetings where you actually hear the views of experts as to what they do. And what you'll find, even though there are guidelines, and we've contributed to these guidelines, we will do slightly different things. And we mentioned the term earlier that guidelines are guidelines. They provide guidance, but they're not tramlines that you have to stay within. So when we come to specific scenarios, don't be at all surprised if you hear different things. That's allowed. You know, medicine is an art as well as a science. So just as a backdrop. So you've heard already that hypopara is a rare disease. Some of you have experience in managing it. But even for the very specialist centers, you're talking perhaps a couple of hundred patients on the books or many tens of patients. So a lot of what we've derived from the guidelines, again, as Stefan has said, is rather consensus-driven. But I fully agree that where perhaps medical science has been afraid to go in the past is to come off the fence as to what do you do in a scenario because there's not enough evidence. But my view is very much that what you can do by providing guidance is that you can restrict practice from outlandish practice on the right to outlandish practice on the left and have a core of what is sensible and good and safe practice. So the signature biochemically that already has been described, that in chronic hypoparathyroidism, we see a picture of either absolute or relative PTH deficiency linked to hypocalcemia, raised serum phosphate, the reduced levels of the active form of vitamin D, excessive calcium going through the kidneys that cannot be reabsorbed and putting the kidneys at excess risk. The classical neuromuscular symptoms, and I think this is something that as you see people with hypoparathyroidism, you come to recognize that the symptoms that they describe, and as I was listening to Stefan's talk, listen to your patients with hypoparathyroidism. Often what they'll say, they're seeing a doctor that perhaps doesn't have great experience with hypoparathyroidism, and they'll say things like, I know this sounds odd, but I get this really weird symptom that. And then they'll tell you what their symptom is. And you say, yeah, I've heard that. That's really, I've come across quite a lot of people. And the relief that patients get from seeing a doctor who actually understands that this weird condition that we control very poorly, that's recognized. So listen to your patients and give them time, because people can get labeled with inappropriate labels and diagnoses. But the neuromuscular hyperexcitability is a cardinal feature, but there are many, perhaps I would say, neuropsychological features of this condition that we need to be more tuned to as well. Quality of life is a big, big factor. So much activity in mineral metabolism around quality of life, and that'll be covered later in the day. And I'll touch a little bit upon bone health as well. So the clinical burden, this is reiteration rather than repetition, because you will see similar themes going through these talks, that this is a multi-system disease. There's very few systems across the body that don't get affected by hypoparathyroidism. The reason that I'm showing it is where these red arrows are, that our conventional therapy, while we try to treat the things that are easy for us, i.e. the calcium, let's get the calcium sorted and we've done the best we can for the patient. Oh no, that's part of the job. But by doing what we have been doing, we increase the risk of renal disease and we increase the burden upon the skeleton as well. So the therapies we use deal with one part, but actually are etiologically linked with causing longer-term morbidity in these patients as well. So our challenge, I suppose, in a very much overarching way, is trying to get our head around a condition that is an age-old condition that we've only just starting to recognize can be treated in, I would say, the appropriate way. Because the cliche is that it's the last remaining hormone deficiency state that we don't treat with the hormone. We put some workarounds in and hope for the best. That's what conventional therapy has done. And of course, that last slide that showed you all these manifestations represent what's gone before. So these long-term consequences of the condition represent the fact that we've only used calcium and vitamin D largely. So is there a way that if we have a more novel way of treating it, that those complications will melt into the background? And of course we don't know, because we haven't lived that long with new therapies. The other odd thing is, when I was talking about listen to your patients, every patient is quite different. And I'll show a slide later about the interaction between the doctor feeling very pleased with themselves because all the numbers look good, and the patient saying, but doctor, I feel rotten. And sometimes the patient saying, I feel fine, and the doctor says, hang on, your bloods are rotten. So there is a great degree of heterogeneity in the way in which this condition expresses itself. So some patients do very well, perhaps surprisingly well, but there's a substantial number that don't do very well. So there is a heterogeneity, and you have to treat everybody as an individual, and the guideline tries to provide an individualized approach to patient care. So what is optimal? What is the ideal? Well, it's kind of getting everything right that we can see, and the patient living a fulfilling life and not having morbidity and excess mortality associated with the condition. But I think that still needs work and to be defined. So what I'm going to do is to pick off some of the elements of the guideline that a number of us in the room have been involved in, and go through those guidelines, but then to add a practical element as to how you go about doing that as well. And Stefan's done that, and some of what I'm talking about has been covered, so perhaps we can catch up a little bit of time through some of this as well. So the guideline is around treating people with hypoparathyroidism, but having that focused approach to dealing with the individual. So it's personalized and holistic. And those are really kind of great words, I think, in a guideline. You say, well, actually, is this a little bit motherhood and apple pie? What is it you're trying to do? Well, we're trying to do a great job all round, rather than being an endocrinologist that just looks at the calcium. It's quite convenient to do that, and we can feel we're doing a good job. But if you talk to the patient, are we doing a good job? And I'm a great believer that a lot of medicine is more a treatment for the doctor than it is for the patient. So we have to get out of our comfort zone and treat patients, even if we don't know how to do it, we should do the best job we can. So often the easier bit is getting rid of the really severe symptoms of hypocalcemia. We can usually make some impact in that, but that's not the end of the story. The big issue here is quality of life. I'm not going to talk an awful lot, but I know later on that you will have a lot of coverage of quality of life in hypoparathyroidism. Target range of calcium, sorry, I'm going to drift into millimoles per litre now, just because you can do the calculations back, is 2.0 to 2.3 millimoles per litre, towards the lower end of the reference range, or even just a little bit low. It depends upon how the patient is perceiving their symptoms. And again, as perhaps a practical example, we get asked this question by patients is, I know you want my calcium at this level, but I feel rotten and I can't go to work and I can't look after my children. Sometimes you have to say, well, actually, if you're running your calcium a little bit higher, although that perhaps is some risk to your kidneys, if it allows you to lead a fulfilling life, it's a negotiation with the patient. So don't be afraid of, I've said 2.3 is the upper. If the patient can only survive at 2.4, that might be a compromise. And as long as the patient is making an informed decision, that's the way to use guidelines. Not to say, I'm not listening to you. I want you to stay at home because 2.3 looks good to me. Sorry, I'm not being practical here, but just making a point. So we've seen this before, and I'm not going to hover, but simply to say, as Stefan said, this is a 2-hormone deficiency state. And we've got very comfortable in dealing with the calcium side of it, and now we are in the era of the replacing the hormone, and I'm not going to say very much about that because it's not my task to do it, because mine is around conventional therapy. But just to exemplify that this is a 2-hormone deficiency state, and we tend to pick up, we can replace the active form of vitamin D, we can throw in a bit of calcium, and we can help with the numbers, but this, from the data that we have already, revolutionizes the management of hypoparathyroidism. So the conventional approach that we're talking about is calcium, and I'm going to have my say on the calcium and the active vitamin D side of it. It's pretty much aligned. I think from a European model, I think we've got similar views on this, but again, listen to your patients. So it's calcium and it's active vitamin D, and I will touch upon, because it is still part of the conventional therapies, is magnesium supplements. And again, my practical experience of magnesium supplements is perhaps not the same as some others. Listen to your patients. Magnesium is a purgative. If you keep chasing the magnesium to get that 0.1 millimole per litre rise, if somebody's got horrific diarrhea because of the amount of magnesium supplements, is it really worth it? I'll just leave that hanging there. Again, this is a practical session, so I'll just throw that out. Thiazides and their use in hypercalciuria, I'll come back to. And of course, trying to deal with the phosphate. And these are often wicked problems. If you've got biochemistry that's out of kilter with some basic therapy, it's quite difficult to get people back on track just with conventional therapy. So, the guidelines, I'm going to put them up, and as I say, the next slide will be practical stuff. So we talk about having an adequate calcium intake. So that overarching recommendation is carefully positioned. So it's about having appropriate calcium. It doesn't say have appropriate calcium supplementation. It talks about dietary calcium, and of course, in younger people, if you have sufficient vitamin D, you have to struggle really to be dietary calcium deficient and not absorb if you have adequate levels of vitamin D. And this guideline subsection here is, we suggest using calcium supplements if, I think that's a really important word, if calcium levels in the target range cannot be achieved by treatment with an active vitamin D analog. So the emphasis in the guideline is about doing things, I would say, in a more physiological way by giving enough of the active hormone to allow dietary calcium, which is optimized through perhaps doing a calcium calculator with the patient, or for them to do that to see how much their calcium intake is, looking at about 800 to 1,000 milligrams per day. But the emphasis around making sure that you have the active hormone, the active vitamin D, to allow absorption of calcium. And again, this has been touched upon before, that treatment to the doctor is, this patient is taking 6 grams of calcium a day. I'll tell you what, they're not. That's what you're being told. And I don't know if there are any surgical doctors amongst us, but the typical case to me is, please can you see this patient? I've been following them for a while, and I just can't get their calcium sorted out. And they're often taking 6 or 8 grams of calcium and perhaps a trickle of active vitamin D. And they're constipated, or they've got diarrhea, or they're just miserable because of their GI complications. And the relief they get to when you start to unpick the amount of calcium that they're actually not taking, they're probably taking half of it that's just creating chalk in their gut. I remember Bill Fraser, bless his soul, and some of you will know Bill Fraser, used to very elegantly, well, not so elegantly, because that wasn't Bill's style, actually, to talk about looking at plain x-rays of people that were allegedly taking, 3 or 4 grams of calcium, just seeing like a kind of a barium enema type picture. So people who allegedly are taking that amount, either they are not taking it, or if they're taking it, they're not absorbing very much, because it's only about 500 milligrams per dose that can be absorbed, so hence the splitting of elemental calcium.
Professor Neil, may I ask a quick question, just to make this more
absolutely.
lively?
I'm happy. Just throw things at me, whatever. Not literally.
How easy is it in the UK to assure that people have adequate calcium intake? Because in our reality in Portugal, many people are moving away dairy products. They don't drink milk. It's not healthy in their point of view. So is it easy in the UK?
So generally, yes, particularly in younger people where the absorptive capacity of the gut is primed to be able to absorb calcium. And I think in those kind of groups, again, in my experience, is that perhaps they are having a diet that's rich in pulses and nuts and green leafy veg, which again, from a calcium perspective, is very good. So I think there is this perception that calcium is all about dairy products. And while dairy products are rich in calcium, there is plenty other ways to get a good calcium intake. So what I encourage people to do is to go away and do an online calcium calculator. In other words, to, dare I say, empower them to look at themselves rather than to over-medicalize it. So in practice, we're on to the practical part, so it's a good point now. I would say about a third of my patients take supplemental calcium. Just a third. I don't know. Yep, Stefan. Yep, so it does have a role. I'm not saying it doesn't have a role, but I think we should clinically feel liberated to try to get people off calcium. We should try to get people off very large doses, and that's the bottom point here about the North American approach, is lots of calcium and less in the way of active vitamin D. But to your point, it doesn't tend to be a practical point that I've come across, but I think there does need to be the educational element of, if you can ensure that you're taking enough dietary calcium, we can bypass the requirement. And because a lot of people just don't like taking calcium, they'll jump at that opportunity.
I think it's impressive. 1/3, it's impressive.
Yeah. Okay, yes, and now just getting into calcium salts, the vast majority of usage. Again, I don't know how much geographical difference there is, but calcium carbonate is by far the most commonly used. And again, I think Stefan touched upon this before, that needs an acidified environment to be absorbed, so taking it with food, it makes it more palatable as well. Calcium citrate, I very rarely would advocate calcium citrate. Sometimes patients, just through tolerability, find that they prefer it and they will source their own, which again is fine if they need supplemental calcium. But just raising the point really that it's only a relatively small amount of that calcium that will be absorbed. Otherwise, it just sits in the gut lumen and causes problems with digestion. And the pill burden, there was one member of the guideline group in particular that was pushing hard on pill burden. And again, let's think of this from a patient perspective rather than it seems to fit the bill from the way that we prescribe, but taking numerous tablets or somebody pressurizing you to take numerous tablets today is a problem in its own right. So pill burden, I think, is a significant issue. And sorry, just perhaps I should just come into my mind now. It was our colleague from the US Endocrine Society that was pushing hard on pill burden, and that's to demonstrate to you that this is an international guideline. It is European strongly, but I think that's an important point to this guideline. It's not just about what do we do on this patch. We had very strong US input and very vocal, challenging, appropriate. The guideline group was a pleasure to work with because it was very dynamic and we challenged each other, and that's what resulted in this. But just to say, there's US input to this as well. On a potentially positive note around calcium, it is possible for calcium in the gut to bind phosphate, and we know that hyperphosphatemia is an issue. So with the calcium, you may get some phosphate binding in the gut, so you can potentially reduce hyperphosphatemia. I must admit, practically, I tend not to try to use that. I don't know, does anybody feel that that kind of works in practice? I'm not getting any vociferous nods. Oh yes, a point around, again, this is very practical, talk to patients. Women with hypoparathyroidism will often say in the lead up to their period, in that period of time, they often find that they have more symptoms. So to potentially front load that period with some as required calcium is important. Even those not having regular calcium, I often say, metaphorically, have some calcium in your back pocket, have it in your cupboard at home. If you're having a bad day, then just to pop a couple of calcium supplements, I think is an absolutely fine thing to do. People who are very physically active as well, to take some extra calcium before going for a run or having even again, in my experience, people who are having a stressful period in life, psychologically, may find that they benefit from that. So rather than trying to change the active vitamin D around a short-term issue, to have some calcium to support would be the approach. And again, that is just a local practice thing. Again, I look across the front row. I got some nods there. So I don't think it's too outlandish. But again, it's practical. Listen to your patients. Another practical point, of course, don't have your calcium taken at the same time as your levothyroxine, because often you've got hypopara and hypothyroidism. And patients are pretty good at that, but otherwise you'll inhibit the levothyroxine absorption. So what about the vitamin D in the UK? Yeah, I think it's fair to say, at least my practice, I use more alpha-calcidol than calcitriol. I think it's a style thing rather than anything else. Potential is once a day as opposed to multi-day dosing with calcitriol, although I think there is variation around that as well. As a general rule of thumb, and this is shown out in the typical dose ranges suggested here, that calcitriol is about twice as potent as alpha-calcidol in causing a calcemic effect. So that's important to know from a patient perspective and from particularly a non-specialist perspective as well, that they are not equivalent. There is approximately 2 times potency difference. Changing dose, how much do you change by? It depends upon the scenario they're in. If you're in an acute situation, you may make bigger dose increments. If you're in an outpatient setting and you're just, what I would say is tweaking towards an ideal, then probably smaller changes as demonstrated here. But because you're changing the system with a fundamental control element of calcium, you need to be on top of that with a blood test, ideally within a week or 2, again, dependent upon the scenario, the acuity of the patient. So even if we do a good job with our basics, our calcium and vitamin D, how do we fare? The doctor sits back in this chair and says, I've done a great job because those numbers look great, but what about the patients? So this is from a couple of, 4 years ago now, looking at the linkage between calcium being in an ideal range and how the patient feels. And you can see that about half of patients had calcium that was satisfactory but with low well-being. The purple quadrant, which is about a quarter, isn't it, is low calcium and low well-being. The green segment is appropriate calcium levels and feeling fine. So that's where you want to be. You want to be green. That's why it's green. And this unusual section here that I have already alluded to is low calcium but feel okay. You know, that is weird, isn't it? I can think of my group of patients now, and I don't want to be any greater than 1.5 millimoles per litre because I feel fine. You try to get me up to 1.9 and I feel rotten. Those patients exist. And it's tricky. So this, I think, is a great demonstration of the heterogeneity of what we think from our perspective, objectively looks good to how the patient feels subjectively. And it's only the latter that really matters from living one's life. So if we are achieving a reasonable job with the calcium and vitamin D around those primary targets, the primary targets are minimizing symptoms of hypocalcemia, improving long-term prognosis, maintain calcium levels towards the low part of the range, and optimizing quality of life. If we can do that, we should then be thinking of these secondary parameters around normalizing 24-hour urine calcium excretion, phosphate, magnesium, and also the native vitamin D level at an adequate level, chosen as 75 nanomoles per litre here. So these are the secondary factors, and I'm just going to talk a little bit about those in practical terms. So to get to the secondary, you need to have optimized your primary. In other words, trying to get the patient to feel as well as possible from a calcium perspective, the quality of life, and the blood tests being where you wish them to be. So if you have hypercalciuria, and this can be a real problem, if you've got substantial hypercalciuria, again, my experience is whatever you try with conventional therapy, you're probably not going to completely normalize if it's substantial hypercalciuria. But the techniques that have been suggested here is to play around with your dose of calcium and vitamin D, which can be a bit self-defeating because if you have a low normal calcium, hypercalciuria, you try to reduce your calcium and or vitamin D, then probably your blood calcium falls, the patient becomes symptomatic and you improve hypercalciuria. So that often, again, in my experience, tends not to be terribly effective. Low salt diet. If you've got somebody who has a hugely high salt diet, then reducing that, I think, can be practically helpful, but it's always worth considering. It's always worth asking the questions. Thiazides. Can I do an impromptu now? Who thinks thiazides are really helpful, really properly helpful in hypercalciuria due to hypopara? I don't think they're very good either. But it's the right thing to do. You know, we shouldn't not go there, but actually to try to get a significant impact from a thiazide in the real world, I don't think they're terribly helpful drugs. But at least from a theoretical standpoint, they should work. And I think on the next slide, I'll talk a little bit about, then you run into problems with hypokalemia, and then you get some symptoms, and then you're supplementing with potassium, and it gets very messy. But anyway, thiazides, that's an appropriate thing to try and to consider. If the phosphate is high, then dietary modification is appropriate, although at a recent, I think it was a meeting of Parat, and Pascal Lullier was talking on this, and he was just saying how miserable it is to try to get onto a low-phosphate diet. All the nice things in life disappear if you're on a truly low-phosphate diet. So again, it's a doctor kind of easy words, but practically, and I think this in the context of people with chronic kidney disease, it's a miserable existence. So again, look at it, but I think it's unlikely to be the primary way of dealing with this. Things that I've kind of avoided saying is that if you can't manage the hypercalciuria via conventional means, it's an indication for PTH replacement therapy. Similarly, if you can't manage the hyperphosphatemia with conventional means, it's an indication for PTH replacement therapy. But I think, Ellen, you're talking all about PTH replacement therapy, so I'm not going to say any more about that. Hypomagnesemia, I've touched upon already. Magnesium supplements can be difficult to take at high doses. It's important, particularly if you have significant hypomagnesemia, then absolutely that can cause significant problems. But again, from a personal perspective, if you have marginal hypomagnesemia, it depends how easy it is for the patient to supplement that into the normal range, but you don't want to give people lots of side effects by just creating that difference. Vitamin D, from plain native vitamin D, vitamin D3. An important factor here is because GPs often get mixed up. They'll say, hang on, you've got this patient on 2 types of vitamin D, and you say, yes, that is the intention. So it's about clarity with an active vitamin D and native vitamin D. And I say the target level that we proposed was 75 nanomoles per litre. So from a practical perspective around hypercalciuria, I've probably said most of this already during that first slide, perhaps I'll mention it in passing. So from a more generic perspective, if we look at degrees of hypercalciuria in the general population, then that is a predictor of renal calcifications. But we don't have evidence within hypopara itself that that is the case. But the inference is that if that's the case outside hypopara, then to correct hypercalciuria is the right thing to do to reduce the risk of renal complications, although we don't have data because this is a rare disease, and so it's not a data-rich area. I've touched upon about reducing calcium and vitamin D. I've talked about thiazides, that if you're going to do it, then you need to get into not just the standard antihypertensive 2.5 milligrams benraflumethiazide type dose, but to 5 milligrams twice daily. And then from the hypokalemia perspective, adding in amiloride can be practically helpful, but keep a close eye on the electrolytes if that's what you're going to do. Hypophosphatemia, I've spoken about the difficulty with reducing diet. Calcium supplements, remember I said earlier, can bind phosphate in the gut to reduce absorption of phosphate. Again, I've got no experience, I don't know if others have, around true phosphate binders in this setting. There's no published data in this area. Magnesium I've spoken about, and the vitamin D, mentioning that explain to the primary care doctors and to the patient as well that taking plain native vitamin D as well as the active form, and from an experience perspective, people who take that often from a well-being point of view feel improved if they're 25 hydroxy, their total vitamin D levels are at an appropriate level. So don't neglect that. Because they haven't got, or they've got deficient levels of hormone to activate 25 to 125, it's still important, again, somewhat pragmatic, rather than an evidence-rich area, to have appropriate levels of total vitamin D. What about moving into monitoring? We've heard about this already, measuring PTH at least once a year. We've spoken about potential recovery, and again, there was one member of the guideline group that was particularly vociferous on this. And I think from a case study perspective, I remember something like 15 to 16 years post-diagnosis, there's been documented recovery. I think that's right. It's case report based rather than long-term longitudinal studies.
So, Professor, in your perspective, should this be forever? Annual PTH forever?
I think using the likelihood of pickup, I think, is low. But if I'm the patient, I want to be picked up. So I think keeping the calcium towards the lower end of the range allows any endogenous parathyroid function to express itself. And I think, again, linked to this, that people with hypoparathyroidism who have undetectable PTH tend to fare worse than those with even suboptimal but detectable levels. So I think the short answer is yes. That yield of finding the case, I think, is quite low, but with the fact that these patients with this chronic disease will be under medical attention, I think ticking that PTH box annually, particularly if you're consciously thinking this is the time of the year, perhaps we can pare back, and I think Stefan mentioned this, pare back on either the calcium supplementation or to reduce your alpha-calcidol or calcitriol by 0.25, but to explain to the patient what you're doing and why you're doing it. Because there is, of course, that possibility that they may become a little bit more symptomatic around the time that you're testing the system. And of course, this is new in this guideline. I don't think it's been mentioned anywhere before. But of course, it is very much with a let's not forget that a few patients, even after a year, 2, 3, 4, 5, will have autonomous endogenous production of PTH. And, a way of getting off it, calcium and vitamin D would be great. So I think yes.
Can I ask something? Because it touches upon this notion of the partial or subclinical hypoparathyroidism, which was very discussed in the Paragraph document. So I was wondering, say that we think that the patient has a partial chronic hypoparathyroidism. How would you change your management, or what would be different? Would you be doing different monitoring in terms of their long-term complications, or what?
Yeah, so I think we don't know. And I think that links to the scenario, was it Luis, I think, put to Stefan around that 10 years later type case, because I was thinking that's probably a case of partial hypoparathyroidism, somebody who's just getting by with some endogenous, but not enough to mount a physiological response to deal with every day that comes. I think it depends upon how it's how it's affecting the patient. If the patient has some endogenous PTH and they haven't had any issue for years, if they present to you because they've had an intercurrent illness, for instance, and they've dropped the calcium, they've become symptomatic, in a similar way to how we manage a short synacthin test that's just a fail, you know, and a kind of a sick day rules type of approach. So I'm trying to think whether I've actually used this in anger in clinical practice. I don't think I have. But in that scenario, I think it's a discussion with the patient as to the risks that even with partial hypoparathyroidism, you still could have substantial hypocalcemia and get yourself into trouble if you become unwell through another reason. I think at least having a rescue kind of pack of calcium, probably, and then it will come down to the patient's perception of risk. I think most people would say, okay, I'm happy to take a really low dose, 0.25 micrograms of calcitriol and have some calcium in the cupboard. Does that change the long term? Does that mean that they have a lesser risk of end organ effects? I would say it feels like they probably would, but I don't know. No, but it's a good one to raise, isn't it? And that's what today is about kind of odd situations that we come across occasionally and how we go about it. But I just came into I quite like the idea of if a patient is reluctant to have that, you know, mildly failed SST type of sick day rules approach, at least you've hopefully established with them that there is a problem, it could raise its head again, and this is what you do, and then you come back to me. And if you've had another one of those, I think to start a baseline low-dose therapy would be appropriate. Okay, so we're just touching upon routine biochemical monitoring every 3 to 6 months. My practice, some of my patients I have contact with once a year. You know, if they're fine and stable, they know how to contact me. We have a nurse helpline. So I am very much around patient empowerment, not being over paternalistic. I was talking to colleagues earlier about not over medicalizing. If you're somebody with a chronic disease that is stable, it's really important they know where you are. So I think bringing people up every 3 months, if it's always all the same, that's not my style, but that is very much a style approach, I think. It's not a right or a wrong. But the guideline says every 3 to 6 months, which I think is entirely reasonable. It's quite, it's staying all over the patient in case there are perturbations, that there's something that we can do about it. We've mentioned the importance of, if you change therapy, the effect is over a day or 2 or 3, so you don't want that patient to not be reassessed within a short time frame. And the other thing is that totally agree with Stefan about, I think, standard practices. We tell our patients about tingling, twitching, numbness, cramps. I think what we should document, and we should in our letters and say to the patient, is abdominal pain, constipation, thirst, headache, because hypercalcemia can be a big problem. And if you see enough hypoparathyroidism, you see a patient that's chronic, that's stable, the next thing is they're in hospital with a calcium of 3.2 and pre-renal failure. Why does that happen? it does happen. So it's important that the patient knows to be alert for the symptoms of hyper as well as hypocalcemia. Last couple of points at the end here, because this is different. I think this happens at the moment, is routine imaging of the kidneys. And of course, patients who've been used to it to say, we don't really need to do this anymore. That's a bit of a message to the patient. But from a guideline perspective, we said that there is no requirement for routine ultrasound or CT, KUB, whatever it is you tend to do, unless there are symptoms to suggest that there is something going on where you may find something that's going to change your practice. So that is very different in this guideline. Bone density, a bit of a wicked problem. I don't know, Eleanor, are you talking much about bones and bone turnover and bone density? Okay. So we know in hypoparathyroidism, you take PTH out of the equation. PTH tends to steal calcium from the skeleton. That's the way it works. So without PTH, bone density at its face value tends to be higher. Bone turnover markers are lower. So you have a kind of a more frozen-looking bone, and that you could say, oh, this bone density is high. This person is not at risk of fracture. So DEXA in its own right doesn't really give us the information we think we're looking at. So don't get too reassured. If bone density is high in hypopara, we expect to see it. And we know that if you give PTH, then actually you re-establish bone turnover. Bone density is temporarily reduced and turnover markers temporarily rise to re-establish a more physiological state. So how do we use DEXA? We said that in the guideline that we don't have DEXA as a routine component of managing hypoparathyroidism, but you look at the patient holistically, and whatever your nation's approach is to what the indications for DEXA, apply those on top of those cases of hypoparathyroidism. But I think bone disease and hypoparathyroidism is tricky. I think it's tricky. Anyway, I'm going to leave that one there, and I hope I don't get a question on it. So not routine DEXA. We've spoken a lot about parathyroid gland recovery. Biochemistry checks we've spoken about. Renal imaging. ADH1 we've heard about, where there's greater degrees of hypercalciuria, so you might want to treat those patients differently. And the rest we've covered. And so in summary, conventional therapy does a reasonable job in some patients at correcting the calcium. It certainly does not improve. It potentially makes the skeletal dynamics worse. It tends not to impact in a positive way on quality of life. And we know that it can add to the problem of hypercalciuria, and also with high doses potentially linked to ectopic calcification. From previous guidelines, how well are they adhered to and how well are they met? So this is the Italian group looking at the old, not the current, the old ESE guidelines, showing that even in a specialized center who are very good at this, these are achieved in only 66% of cases. Why is that? Because we haven't had the tools in the bag to deal with the problem until now. And now we are at a point, a revolution in the care of hypoparathyroidism with replacing the hormone. So the guideline is very much personalized and holistic. The figure 3, which many of us will have a heart sink moment when we mention figure 3 from a guideline perspective, so much time, effort, and energy went into that algorithm, which I think is robust and watertight. It's complex, but it carries you through management of hypoparathyroidism with clear targets. We, as the first guideline, indicate where PTH therapy should be considered, and also long-term structured monitoring as well. So it's been really delightful to be part of this group from the individuals shown here. And I've just got some very brief cases to go through. So this is phone interaction. Those of you who felt, oh gosh, I haven't touched my phone for at least an hour, this is your opportunity to pick it up and use it. Although I'm not naive enough to think that you haven't been using your phones during the last half an hour. So if you scan this, then there's just some simple questions that I have, and you'll be able to interact, and in a similar way, how badly or how well have I done, or how badly or how well have you been listening to answer these straightforward questions. So hopefully you're at a point where you can interact. So, first question. How do alpha-calcidol and calcitriol compare in terms of potency? Option A is that they are broadly equivalent. B is that alpha-calcidol is twice as potent as calcitriol. C is the opposite. Calcitriol is twice that of alpha-calcidol, or fourfold factor for D and E. So I was hoping that things would start moving on the screen. Is it giving you what you're expecting to see? Ah. Are we likely to have a fix soon, Carolina, or we are? Shall we do old-fashioned for the first one and then ready for the second one so we don't lose time? Okay, so A. I don't mind. You can go green or red. Just hold up a card for A. B. C. D. E. You've all been very attentive. Very good. So do we need to... I'll tell you what, let's go old-fashioned for the next one as well, because I'm not perceiving an IT fix from the back of the room. So if we go to the next one... Okay, so which diuretic dose and frequency is appropriate? Perhaps that should be in an attempt to reduce urinary calcium excretion. So I'll let you just read through. A, amiloride 10. B, benraflumethiazide 2.5 once a day. I'll make it up. C, benraflumethiazide 5 milligrams twice daily. C, D, E, I'm not going to commit. It's C. So the only dose that I touched upon during this is high-dose benraflumethiazide. So that's the only one that would potentially work in having a significant impact on hypercalciuria. And it might be that we go to questions,
Yes.
I suggest.
Maybe. And we have one or two questions from the audience. Can go right away.
Yeah.
Can we have microphone? Do you have another one?
Of the two vitamins D, if I quite understood, you always use from the beginning the native and the active vitamin D, because here I don't think, but my colleagues can say. Usually, I think we use only one of them, usually the activated. So the rationale for that is, could you please explain it?
Well,
better, and also the measurements in the, we should measure only the 25, or you also recommend to measure the 125? Okay. Thank you.
So not the latter, but I'm going to ask Stefan to answer that, because that's right up his street.
Yeah, so we take care of both vitamins, so the 25D and the 125D, because there's an endocrine function of vitamin D, so that's the calcitriol, the activated vitamin D, that circulates around as a hormone. This is what we replace with activated vitamin D. We have to take care of this. This is part of the conventional therapy. But you have to remember that the circulating concentration of 25-hydroxyvitamin D is about 1,000 times higher as compared to 125D. And 25-hydroxyvitamin D is not just serving as a precursor for the 125, so that the active hormone is produced. It has its role on its own, because there are cells that taking up the 25D and intracellular converting it in kind of an autocrine fashion in the calcitriol within the cell. So both are important. These are different pathways. So one is the endocrine function of the calcitriol, and the other one is the tissue function, the autocrine, paracrine function of the 25-hydroxyvitamin D. So it's very important to keep an eye on both. This is, however, pathophysiologic consideration, but it's very important to take care of this, because this is a very frequent question in the clinic.
One last quick question, I think, third row. Microphone.
Diuretic to control the hypercalciuria. So you think we can use, is useful to use hydrochlorothiazide, or?
In combination maybe with the miloride.
Because we don't have this one available.
Sure. So I think chlorthalidone and hydrochlorothiazide, and as you say, particularly with a combination because of the potassium issue, I think absolutely. It's reasonable, I would say, as a therapeutic trial. In other words, if you're in the scenario where somebody has significant hypercalciuria, you're making an attempt to correct it. But if it's not having an impact, I would say stop it. But yeah, whichever thiazide that you have available to you at probably a higher dose than you would use naturally.
Maybe I can add from my own history and from my own learnings. I always learn from my mistakes in medicine. This is very critical as a doctor. But with regard to the hydrochlorothiazide, we also have that in Austria, and we used to use a dose that we use for hypertensive, so 12.5 milligrams or 25 milligrams. But what I learned, of course, is that you have to use a much higher dose. So, for instance, 50 milligram in the morning, 50 milligram in the evening. And of course, this is also doing some alterations in other electrolytes. So this is the limiting of its use. If you use it at a very low dose, it doesn't really make sense. If you use the standard high dose for hypopara, you will face some problems with other electrolytes. And therefore, its use in my clinical practice is very low.
Great.
Okay. Well, I think we have run out of time. Thank you very much, Professor Neil.